Welcome to the webinar, Exploring New Digital Care Paths. My name is Geert Smits, and I'm the CEO of AZ Monica, which is a hospital in Antwerp. I will be moderating this webinar. Now, COVID-19, the corona crisis, has had a tremendous impact on the healthcare in Belgium. And I think from a positive side, hospitals have been changing their ways of working almost overnight, which resulted, I think, in an excellent management of the first peak, and I hope also the second or the third peak will be managed very well. But there are also some negative sides that we encountered. There were some shortcomings in our system or in our processes, resulting, for instance, in postponing some of the important diagnoses and treatments for patients. And that's something that we see now. Also, the collaboration between the different players in the healthcare system was not very well. And I'm thinking about the connection between the patients, the first line, the elderly care organization, the hospitals, the government, and so on and so on. That was not always running very smoothly. One of the solutions to these problems is digitization, e-health, digital health. There are different names for it. Now, I think most of the hospitals did find some digital solutions throughout the crisis. For instance, the digital flow of information with the government, the digital with the government was, I think, okay. Also, digital consultation was something that was introduced or even enhanced within hospitals. But these are, of course, point solutions, and today's topics will give us a more broader view on the possibilities of intra and extramural digital care paths. And this should help us to solve a number of problems, but more important, should allow us for a more patient-centric approach in our hospitals and beyond our hospitals. There will be two presentations, one from Mark Evans and one from Arlette Stierman, following by a discussion. The question tab should be active or should be active shortly, and you can ask questions there. And after each presentation, we will have a short time for a number of questions. And then at 3 p.m., and I try to keep me on that timing, at 3 p.m. we will have a more elaborate discussion, panel discussion, where also Rudy Bellen and Frank Dendas will join us. Now, the first presentation is from Mark Evans. Mark Evans is head of the consulting operations and international markets at Philips Healthcare Transformation Services, which is HTS. Mark leads the consulting and operation teams for Philips in the Healthcare Transformation Services Group, and working with Philips in-region principals and regional consulting teams. He supports the growth and the development of outcomes-focused solution and delivery of transformational change through expert teams on the ground. Working for and with Philips' valued customers, his goal is to achieve the quadruple aim of improved outcome, improved patient experience, improved staff experience, and reduced cost. So I give the floor to Mark.
Thank you very much, Geert. Thank you. So it's a pleasure to be here and to have this opportunity to talk to you all. I guess we can bring the presentation up now and we can start talking to that. Whilst we do that, just a little bit more of my background. I probably spent around 15 to 20 years in complex transformation programs, particularly in healthcare in the last 15 years across the globe. And I think we're all at a point in our careers where this is a new and challenging time, and but also a new and challenging opportunity that we need to take. So I'll take you through some of what our thinking is and what are let's say the ideas that are inspiring us, and hopefully by sharing those we can stimulate some good discussion. So if you go to the next slide, please, Arletta. So there's a massive change happening right now. We're in the midst of a global crisis, which is drastically affecting demand on the healthcare systems and how patients and providers interact to meet that, both in the crisis situation that we saw earlier in the year, but in the subsequent weeks as we've tried to navigate this challenge. It's a disruptive change, but I think a positive disruptive change for health systems that's being accelerated. You know, there's a real need for payers, providers, and patients to truly leverage data, technology, and digital methods to transform the way care is delivered, to the way care is accessed, and also by doing so, hopefully positively affect cost, experience, and outcomes. But it's happening right now. We're in the midst of this, and you're probably all experiencing that as we speak. And I thank you again for taking time to attend this webinar, because I know you must be all very, very busy. So on the next slide, please, Arletta. So COVID-19 had an immediate effect. We know that. We saw a reaction, a response that probably none of us were ready for, but I'm proud working in the healthcare industry to see just how inventive, adaptive, and industrious in many ways our fantastic healthcare staff have been in responding. We've seen a tremendous pace of change. We've seen patients and providers responding in several ways. You know, firstly, how willing, in fact, and how demanding patients have been to embrace the concept of virtualized care. They don't want to come to hospital. They want to be receiving the same kind of care and support, but not necessarily leaving their homes, which is really something we've been probably trying to develop for many years to reduce the cost of care, but it's not been embraced in the same way. We've seen health systems react swiftly to deal with that first wave of the crisis, and now turn their attention to future resilience. How will the healthcare systems respond if there's a second wave? How can we stop the spikes, or if we have a spike, how can we deal with that? And I think equally important is we've seen a strong desire to understand how to catch up and to stay in control. So everyone's acutely aware, I think, that there is an unmet demand or a deferred demand that has been a result of this crisis. Next slide, Arletta. Thank you. So it's concerning to me, and I'm sure concerning to you, that the future demand will not only consist of existing and future patients, but also those that were deferred or unmet or untreated in the earlier part of this year. Recent research shows that something like 70% of patients deferred or cancelled treatments, which is quite a startling number. 1 in 10 cancelled their treatment altogether. And that was driven by a combination of lack of access to treatment, because hospitals were locking down as well, but also probably more importantly, the self-preservation response, which was, I don't want to go anywhere near a hospital, I want to stay safe in my home. But what that means is those patients' needs haven't disappeared, and there will be a backlog of both planned and unplanned care that is not going to go away and is going to need to be managed. So I think that is something that is going to require health systems to change, and I'm sure you're already planning and thinking about that. But if we go to the next slide, I think what's also changed is patient behaviour. So there is a real measurable difference in the appetite and willingness of patients, and in some ways you might call them consumers, to embrace new models of care. You know, care pathways that will need to change and incorporate a high degree of digitisation, because we are moving more towards a model that is closer to home, closer to the point of care, out of hospital. The use of data is happening right in front of our eyes, you know, to track, to trace, to screen, to test, to monitor, to advise. The public as a whole is demanding more information about their own personal health. And we need more information, because we not only have to care for singular patients, but the whole cohort or population of patients and citizens that are under our care. So I think this patients will believe that this is better for them. In fact, I think recent survey results showed that they believe it's better for their health, it's a lower risk, they have more access, and it's more personalized. So actually, most patients would be delighted that healthcare is moving in this direction, if only the disruption that it's meaning to their own routines and their own norms. I think we're very quickly adapting to those. So the change is going to be permanent. I don't see that our populations are going to go backwards in their needs and their voice for change. So given all of that, next slide, thank you, Aletta. We know that COVID's acting as an accelerator, but we already had challenges. We had insufficient access to quality care. We had escalating healthcare costs. We had an aging demographic, and still have an aging demographic with complex needs and comorbidities. We have to manage an increasingly frail and elderly segment of our population, whilst we have skilled staff shortages that are under more pressure now than they ever have been before. Although I would say that one positive outcome of this crisis, certainly in the UK, is that staff, nursing, doctors, support staff in hospitals have gone from being considered almost like second-class citizens by the general public and the government to being considered heroes, and managing us through what is probably a crisis that we'll never see again, we hope, in our lifetime. But we have the opportunity, we have the new generation of providers where we see healthcare providers joining up in networks, we see retailers, payers, startups, all providing different forms of care in that continuum. And both health savvy and tech savvy consumers and tech savvy professionals, which I feel makes this a fertile ground for change in the aspect of digitization and new models of care. And that to me is exciting, because the door is open, the barriers are lowering, even the barriers to procurement, to commercial models, to how we engage between private and public organizations, those are lowering to allow speed and speed of change. So this is a very busy slide, and it's busy in terms of digitization because there is so much going on. If you just think about things like cloud technology, which gives us unparalleled access to processing power and storage, and is rapidly heading towards almost like a zero cost resource. We have sensors everywhere in every aspect of our lives, from weight, activity, sleep, vital signs, even nano cameras, and background technologies that listen to us and respond to our voices. We have digital techniques that interpret that data and information. So out of the field of unstructured data, we now have artificial intelligence, machine learning, algorithms that can interpret that data and turn it into actionable intelligence. And what I mean by actionable intelligence is, if you don't act on the data, then nothing changes. So we need that intelligence to narrow down the field of view to what are the decisions that are most risk reduced that I can take. There's new interfaces. We interface with technology differently. Conversational interfaces like Alexa, Siri, Google Home, as uncomfortable as it may seem to use those sort of things, they allow a different way of interacting. And there's a whole host of other technologies that are far outpacing our ability to change, but are there and are available and accessible. And it's about harnessing that technology. And I think, for Philips have talked about for 20 years this concept of ambient intelligence, which is that technology sits in the background, almost transparent to the user. And if you think of that in healthcare terms, it means it knows who you are, it adapts to you, it provides information about you. And maybe one day soon, when you interact with a healthcare intervention, a consultation, or even a piece of equipment, it would already be adapting to your very specific needs. So the ammunition is there, the capabilities are there, and the need and the pace of change is there. Now we talked, you heard in my introduction about this concept of the quadruple aim. We know that there's a constant striving in healthcare to improve outcomes and lower the cost of care. Value-based care is all about that. You know, how can we get the maximize the outcomes for the patient whilst reducing cost of delivery of care? But that's not the only part of the story we need to consider. We need to consider how improved the patient experience is. And the reason I say that is because it's been proven through research and through many different studies that your outcome as a patient is improved if you have a better experience, if you can access care more easily, if it's at the point of care where you need it, if you can be more informed and more responsible for your own care, then naturally that you would expect to have a better outcome. And we certainly in Philips never forget the improved staff experience. And the reason why we focus on that is because particularly in these times, it's important for staff that they feel safe, that they have a better coordinated healthcare system, that it's more in control, more predictable. And hopefully we lead to less strain on our very valuable resources in that way. So let's talk a little bit about digitising healthcare, and that can take many different forms. We see three trends really emerging, which we'll talk about briefly. The first trend is for hospitals to be considered as a healthcare network. Now that's not a new term, it's not a new concept, but it's becoming very real. No longer can we have a hospital, and in fact no longer will the hospital be the central locus of cost and care for all patients. We have to have a model that is now looking to be more networked, and the hospital will remain, I guess, the place only for really acutely ill patients or specialist needs. But we are considering the near future being a network of hubs or hublets or spokes or pods that deliver continuous preventative care across the care continuum and longitudinal care pathways. They would be connected. There may be centralized command centers that coordinate the resources and the operational and the patient flow aspects of that network, but they're connected in the sense that providers can connect with each other and patients can connect and access any point or node in the network. Where possible, that would be home-based. It would be closer to home at the very least, and the data would travel with patients to any care setting they happen to interact with. That's no longer an aspiration. That's a need, and it's a goal that needs to be realised in the near future for us to manage in this current situation, but also to drive down the costs and improve the access and experience. Recently, we've been working with the Veterans Association in North America, and we've been trialing out virtual care pods, and these are located in the Veteran Association halls where these guys and girls reside, where they live, and they can integrate and connect with their consultants. They can share various different physiological measurements. They can share information. They can get reinsurance advice on their particular needs and their care. And this is starting to work across 500 hospitals in North America and around 16,000 patients. About 1 in 8 patients has access to that kind of dispersed network of care provision. So I think that's an interesting example of what's possible. The technology is no longer the pacing item. It's no longer the constraint. It's really how do you operationalize that and make it work for your particular situation. I think in that sense, you know, if we're providing that kind of access to care, then we've got to expect that we're empowering patients as consumers. For a long time now, patients have been able to Google what's wrong with them and go into their doctor's offices and probably advise the doctor on what they think is wrong with them, sometimes for better, sometimes for worse. But we see increased patient choice. We saw that in some of the statistics earlier, where we saw patients were choosing not to take the care that was being offered or recommended. We see that patients are wishing to access consultations, access their own healthcare records, get access to always-on human or digital support. And I think what we're also seeing is that there's the opportunity to nudge, to guide, to prompt, to perhaps anticipate needs ahead of time and directly interact with a patient long before there's a crisis or an escalation in their care needs. And I think, and you've probably seen it yourself in Belgium, that our patients really are consumers now of healthcare and are demanding for all the right reasons. Now, when we talk about virtual care, we're talking about that same connecting care providers to this wider network, but enabling remote point of care delivery and diagnosis or assessment, consultation, often supported with AI. But these kind of technologies have been very successful in rural care situations, in third world situations, in deprived areas. But now they may become more commonplace, allowing providers to connect with each other and collaborate, and allowing greater access, as I said before. So let's talk a little bit about access to critical care, which has been very, very prevalent in our thinking in the last 6 months. So we saw in most countries in the world where there was a real COVID-19 crisis, that the fear was that the critical care capacity would be strained. And that's capacity, not only physical capacity, but resource capacity. And I think even coming out the other side of this, we will see that there'd be a resource capacity constraint. Now, you can deal with that in many different ways. You can look at how the capacity is being used and utilized, but also enabling more centralized critical care surveillance through tele-ICU, for example, through audio and video and vital signs connections that allow you to monitor multiple patients in a single sort of environment, using analytics and AI to monitor those various different data points that allow you to understand whether the patient is deteriorating, decompensating, potentially reaching a crisis situation, or alternatively identifying when a patient is actually stable and ready to step down, which, if you think again about the cost of care in that particular environment, moving patients from that environment to a lower acuity care setting is another important consideration. So this kind of virtual telecare can reduce costs, improve care outcomes, but particularly leverage a scarce resource like critical care nurses. And it can operate in a number of different ways. You could have a central tele-ICU facility that's serving multiple hospitals, and there are those around the world, particularly in North America, virtual tele-ICU facilities that are serving literally hundreds of critical care patients. You might have a central tele-ICU in a hospital, and you might equally have something that's more out of hospital. We're currently working through rapid iterative sprints with the US government on what is known as their national telecritical care network. And this doesn't exist now. We're literally building it with them, which allows them to monitor across a mass population in a state or even wider, and provide critical care networking capabilities to anyone that might be in a crisis situation, either driven by COVID or a natural disaster, a hurricane, or terrorism, or whatever might increase the demand, exponentially on critical care. And by joining together various different types of technologies, you can manage the capacity, you can manage the access, you can manage the exchange of information, even down to having wearable patches that monitor vital signs. Some technology that the US government uses in the battlefield for in combat situations, all of that technology is now being accessed for this sort of almost civilian use cases, and we're accelerating the joining up of those things. So of course you are collecting and having to process an enormous amount of data in those scenarios that I've described, not only clinical data but operational data, and by that I mean patient location, where's the equipment I need, where is the staff I need, where are the priorities, how do I synchronize, how do I orchestrate care. That's difficult enough within a hospital. Across a group of hospitals, even more challenging. Across a population or a locality, even more challenging. But these concepts are already successfully operating. The concept of mission control or command centers for healthcare is again not a new concept. I've run and implemented several command center programs with hospital groups that are looking to take advantage of, we have all this data, but how do we elevate the data to a level where it becomes actionable intelligence and it's in the hands of those people that can act on it, and those people know what to do when they see that data, when they have that decision point in the moment, not 3 weeks later, not through data mining or research, but I need to make a decision right now because there's a situation in front of me that needs action. So integrating information is only possible through digital means, and presents its own challenges, but also the opportunities are enormous in terms of the quadruple aim that I was talking about earlier. A couple more examples then I might talk about before I hand over to Arletta. We also are no longer constrained by the bricks and mortar of hospitals. We have these traditionally, the high locus and focus of care has been in these buildings, and they have often led us to try to drive up the utilization and the efficiency of a single location. But we don't need to be bound by that anymore. Technology again has come to a point where we can create office-based cath labs, for example, where actually the bricks and mortar don't matter. We can equip any space within reason to perform what would usually have been performed in an acute hospital. The same goes for example, in India, we're providing ICUs in a container that can be drop shipped anywhere in the country and can provide critical care capacity, just as you could provide imaging or diagnostic capacity in the same way. So I think that relies both on the technology, but also the interoperability, the connectivity, the exchange of data, etc., to allow it to happen. But again, that's not a constraint. The constraint is our speed of adoption and designing the systems that will utilize those technologies and that digital capability. And I think one other thing I wanted to talk about was about managing populations, and the reason why I talk about this is because we all know that these days your care is a continuum, it's a longitudinal journey, and that just because you're not under the care of a hospital or a doctor or in a care pathway doesn't mean that you can't manage your health and manage your well-being. And we've seen this particularly again in the UK. We're hearing the government talking about the challenges they have just in tracking and tracing the incident of the virus amongst the population. So that's an accelerated need. How do I track and trace and screen and test the population to allow me to monitor the spread of the virus, but also to respond to outbreaks and to anticipate spikes. But if you go a lot beyond that, why would we not treat chronic conditions or even lifestyle conditions? So we know that there's a large degree of the population suffers from sleep deprivation. We know that we can tell an awful lot about a person's predisposition for disease by their lifestyle, their eating habits, their drinking habits, sleeping, smoking, exercise, drug use. We know we have genomics data that will help us get a better understanding of how to provide precision medicine to intervene and prevent the onset of certain diseases. So I think we're moving towards a world where, again, consumers like you or I would be demanding that you get an alert when you are starting to demonstrate some indicators that might suggest early onset of a particular condition or a heightened risk. How healthy am I? How prone am I to disease? How might I behave differently right now to reduce that likelihood? That's really putting the responsibility and the ability to respond in the hands of patients and consumers, whilst on our side managing chronic healthcare out of hospital means that we can drive down the cost and increase the value of managing people that are on long-term care pathways. So I think just to sort of bring this to a close, this first section, I'm extremely excited. I've been excited for a long time about the power of technology and data and information in healthcare, because I come from further back in my career. I worked in the aviation industry, and I worked for a company that managed aircraft engines on the major air fleets around the world when they were up in the sky or whether they're down on the ground. And 20 years ago, we were doing remote monitoring, continuous remote monitoring, remote diagnostics, preventative care, proactive intervention for aircraft engines. Now, they're solid objects made of metal, they're not human beings, but the technology existed back then to do that in a very complex way. So I'm delighted to see we have this opportunity to accelerate our digitization in healthcare. And this very unfortunate crisis that we've been faced with is the real catalyst and accelerator for that change. So that's what I'd like to share and have shared. Hopefully some inspiring thoughts, and hopefully we'll get a chance to explore those a little bit further. We can't hear you yet.
Try it again. Is now clear? Okay. So technology, But thank you very much, Mark. It was a very clear presentation, so clear that we don't have any questions. Just a reminder, there is a question tab. You can put in all your questions, and we try to answer that with the panel after the presentation of Arlette Stierman. Arlette Stierman is indeed the next presenter. She's a senior consulting manager at Philips Healthcare Transformation Services. Working at Philips, Arlette has the chance to support hospitals and other healthcare organizations optimizing their care delivery. She does this by growing the Philips consultancy team and by developing transformation methodologies to be used in daily work. Her focus is on connecting healthcare organization, digitization and optimization care processes. So Arlette, the floor is yours.
Thank you, Geert. You can hear me okay? Great, that's great. Let me hide the webcams so I can also see my own screen. Well, also from my side, thank you very much for taking the time to listen in. I see some people have joined halfway the story, so hopefully you caught up a little with the summary of Mark in the end. So my daily work involves looking at care pathways and see how they can be digitized. And what I want to share with you in the last bit of this hour of this webinar is how do we actually do that? And how do you make the choices of what you do and maybe even don't want to digitize? As Mark stated, right now is the time to embrace digitization, because many hospitals and many other care facilities have rapidly scaled up e-health solutions. So in my view, you should stick to that solutions and scale them up. And what is very important with that, and one of the key takeaways of today from my side, is that that can be very successful if you look at the patient perspective, and even not only the patient perspective, but also staff experience is something very important to take into account. Let me start with a few very easy examples, just to give you a hint of what I'm ending with. I'd like to start with the end in mind. And next up, I will tell you how to get to these results. So many hospitals, many departments in hospitals work according to a classic situation. So a patient goes to the hospital, something happens, and he or she goes back again, hopefully back home. And in the top line, what you see is a COVID example. So what happens is a patient needs to go to the hospital, but it's unclear if he or she has COVID. The patient comes there anyway. The digital solution for this is to use an online artificial intelligence screener that guides the patient through a set of questions and determines how large the chance is that he or she has the coronavirus with him or her, and advises the patient on what to do. Should you go to the hospital, or maybe shouldn't you? This gives the possibility, so that's the new situation you see at the right side of this image. This gives everybody the possibility to isolate patients and not unnecessarily come to the hospital, and it saves work from the staff in the hospital as well. The second, the lower part of the image is about regular checkups in outpatient clinics. So we are very used, everybody is, and I think the same goes for Belgium as it goes for the Netherlands, where I mainly work, that we are very used to just going to the hospital for every checkup that we need, whether it's for women carrying a child or chronic diseases, everything that takes a little bit longer, there's a regular interval of patients visiting doctors. This feels good, we're used to it. However, the situation has changed, and there's digital solutions that allow patients to measure their data at home, to monitor their own trends, that hospital employees can actually see as well from a distance using a data platform. They could even start a treatment at home instead of physically next to a caregiver. So in the new situation, we go back to the quadruple aim that Mark talked about. This means less visits are needed. The caregiver even has more information because it's not one point of measurement, one data point. It's a continuous trend. And what's really interesting is the changes in the trend. And as Mark also already rightfully said, is noticing that a patient is deteriorating. And if you start the treatment at home, you could even lower the number of necessary admissions or shorter them, because patients can go back home earlier, because they can also be monitored in a safe way at their own homes. So this is what we're working towards, this and many other digital solutions. What I want to share with you is how do we actually get there, get to this point, because it's not easy to immediately hop onto that level from the point we are now altogether. So there's 4 major steps, and particularly the second and third one I want to share some more details about. So what is very obvious, but I do want to mention it, is that you have to have a future vision of the hospital you're working at or the care network you're working in, which is obvious, and every hospital has this vision, but it's very important because it's the direction to go to. It's the top-down vision. What we work on a lot is to match bottom up, what's actually happening to that vision. So what we feel is very important is to understand the current care pathway, which includes the experiences of your staff and of your patients. And also understand what digital solutions are already there, because you don't want to start from scratch. You want to start from the things, the good things, the great things that were already done or digitized during the COVID period. And what you see in the image, it's an example, a real example from one of our Dutch clients. So it's not meant for you to understand if you don't understand Dutch, so I will explain it. It's about the visual, that this is an overview of that current care pathways with the experience in it, data in it, everything's in it. I will come back to this in a little bit more detail on the next slide. But what's important is that we take a look at the current situation, not only from the patient experience and staff experience perspective, but also from a clinical perspective and from an operational and technical perspective. All these perspectives combined create something you can work with, the current situation you can start from, and you can extract insights from and the opportunities for digitization in the future. So you basically have you create a faraway vision for a new care pathway for hopefully not only a hospital, but a complete virtual care network, because I feel you should have a look at a particular type of patient instead of all different patients in one hospital. Just as Mark talked about the virtual care network. And the fourth very logical step is to next find partners and then start redesigning a care pathway for that particular patient group. So next, how do you actually start this? There's my next slide. So what we start with is for every phase of care, regardless where it is, if it's at home, at a general practitioner, at the emergency, at the hospital itself, or even some other care facility, all these phases from the perspective of a patient, he or she can or cannot go through. That results in a patient journey with everything he or she encounters during this time. Then what's also important is what staff does, the journey of care delivery. The reason it's important to also visualize this, or not visualize it, but assess it anyway, is because digitization of care has a huge impact on that care delivery journey. Imagine always being in the same workplace, being at an intensive care unit, and changing that physical environment for 1 day a week sitting behind the screen. So that's also one of the reasons we look at the current situation, because you might argue, just start designing a new digital situation, more digital situation. But you have to really understand the gap in between what's happening right now and what will happen in a new situation with even more digitized bits and pieces of that consumer journey. I have a little trouble going to the next slide. Oh, there we are. This is to not only give you the theory, but a COVID example. This is what that would look like, what the different phases of care, including the patient journey, could look like in a visualization. So what you see is a person that is still at home in a COVID situation, is not experiencing any symptoms, but still is in need of monitoring his or her health, and be careful, do social distancing. So a lot is happening even before there's any symptoms. And going on to the right of this image, you see that people develop symptoms and could get severely ill or even critically ill and need to recover at the end of the image to the right. So it's not about the content of this image, but the way we represent it. And you will see that in the next bit that we, in our methodology of assessing this, we transform those experiences and those processes in insights. So that's what it's really all about. It's about the needs, the pain points, and the expectations of the people that are involved, and the people is staff and patients. And from that insight, then that is the moment that we start writing down the opportunities to digitize. So there's actually a whole process before starting to really digitize or design your more digital process or care pathway. And the reason for that is that a good innovation should be based on filling in a need or solving a pain or living up to an expectation, because that's the way innovations will actually take root into the ground and really happen. So all the opportunities that you can see as a hospital or as a virtual care network need to be attached to some need somewhere, even if it's a need that's still unknown. And this methodology makes sure that happens. And this is quite theoretical, I realize, so I wanted to show you a true example. So this is a huge thing. So how we usually work is that we make posters for everyone to see. It's quite large, it's a lot of information. I will zoom into a small bit of this in a moment. But this is the story of a university hospital in Germany, specifically the cardiac catheterization department, where we did this exact exercise. So on top, you see again the patient journey, the care delivery, all the small stick figures you see is healthcare professionals. And from there, we derived insights that eventually were transformed into opportunities for digital solutions. So if you have a look at the details, what happened there is that the ambulance, so that's sort of the walk-in area for patients for day treatments, was very scattered. So you had lots of registration areas. It all went back and forth. It wasn't connected at all. And a large part of the time of staff there was taken up by fixing referrals, because they are a third-line hospital. They're not a regular hospital. But also by patient questions that are often the same, very easily answered. And what I always find nice is that you actually see the speech bubbles with quotes of people that came up in this research. So the particular solution for this bit, and this is one of about 10 bits in the whole poster, is to facilitate a patient portal with some artificial intelligence under it to really streamline that process for the ambulance area, as so they called the ambulatory area, in order to gain a lot of efficiency in staff working, save them a lot of time, and make their job a happier job, and for patients increase service levels, and in total be more efficient, which is valuable in terms of money as well. So that's the first example I wanted to share with you. There's another example that I picked for you, and I think there's a message. Oh, no, there's not. The second example is for a whole population, which I find interesting, of acute coronary syndrome patients. So the same thing was done. You see a slightly different but yet similar flow of what happens with acute coronary syndrome patients. This one is in Dutch because it was done in the Netherlands. And we did a same exercise. And the thing is so we mapped the whole patient experience, and this captured the whole process. And what came out of this is the suggestion, and we actually developed that after, to assist patients at home as well to prevent new acute situations, because these are patients that come back many times. At least a lot of them do, because they don't improve their lifestyle. They still pick the wrong things in the supermarket, and they still drink too much. That's all causes of them returning to the hospital over and over again. So from this whole exercise, the opportunity was, let's see if we can find a digital solution to support patients complementary to the actual intervention that happens in the hospital. And one of the things we did next was make a storyboard. This is a storyboard of many pictures. I picked out a few for you to get the feeling of what that looks like, to truly see what the digitized, I must say, care pathway looks like. So first, this is about a person that has acute coronary syndrome troubles. So he's picked up by the ambulance, and at the hospital, he receives an intervention, so a PCI intervention or something that makes him feel better. So what you see in the second image is the nurse that already registers his data through the iPad, which is not very uncommon, but also connects at the hospital some wearables and own measurements with this patient. So he can already see what's happening himself in a dashboard, and his daughter at home, I didn't put in all the pictures, his daughter at home sees the same thing. So she can already see how her dad is doing at the hospital. Once at home, this person gets all these measurement devices. So once or twice a day, he measures his blood pressure. Every week, he puts himself on a scale. And there's a little bit more. They got a smartwatch, for instance, that measures heart rate, and a whole educational program tailored to this specific person, for instance, smoking or not smoking, drinking or not drinking, that gives this person advice on what to do. So very simple. The first day it says, well, don't walk stairs. You just had heart surgery. You're okay. Just sit down, relax, and tomorrow try a few steps. That's what it does, complementary to what the cardiologist does. Meanwhile, the nursing specialist is in touch with this person. So she can monitor his trends, and he can reach out to her whenever necessary. She has a dashboard. She has an overview of her population. She doesn't even have to be close. She can even be in another hospital or another point, wherever she can use a computer. And one of the things we experienced as a team in this part is the usefulness of the whole process we did in front, about really understanding also the staff experience, because for them this was a fundamentally different way of working. That benefited us in the end of this process, and still it was a huge transformation for them. So not a small thing. My final bit, Geert, I'm getting to the end. I know you're timekeeping. This is the slide the one before the last slide. This was a solution that only coaches people, in fact, at home, and make sure you can get in touch with caregivers. You can also expand such a solution to monitoring. Why couldn't you monitor people at home as long as there's a safe way to do that? Because we already monitor patients at the cardiac care unit, and the severity and the intensity with which you need to monitor drops a level every time the patient gets a little bit better, which ends in monitoring at home and releasing people earlier from the hospital, gaining the logical things from the quadruple aim, such as cost and patient satisfaction and smart use of resources. But also, when the patient is at home and doesn't need close observation anymore, there's still a need, a wish, and a use for long-term observation and self-management, as we just talked about, to prevent, for instance, heart attacks. So this is the content bit of my story. Let me give you some key takeaways, not only from what I shared, but also from what my colleague Mark shared. So he started with the statement that this is the perfect time to digitize care in a healthcare system that learns how to deal with pandemics as we go, and may even expect a new peak spike coming up into that. And the three things we talked about is that you should do that in a virtual network, or you can do that on a macro level in a virtual network, collaborating with each other. It's more easy to approach a large population in that. And when designing the actual care pathway that's more digital, you should do that around the experience from patients and staff, because only then innovation will land the way you want it. So that's what I wanted to share with you. So thank you very much for your time. There is half an hour left for discussion. So I presume there is some questions. For now, I put this on the screen. This is what we actually do, Philips Healthcare Transformation Services, just as background information. But I kindly invite you to ask any question to me or Mark that you may have at this point. Thank you.
Okay. Thank you very much. Just checking that you hear me. Yeah.
I hear you.
Yeah. Indeed, we have some questions coming in and some suggestions, but I suggest that we open the discussion panel since we have a very intelligent audience, and also because there are some more local aspects on a number of these questions. Two persons will join the panel. That is Rudy Bellen. He's the Business Development Manager and Integrated Solution and Large Strategic Partnerships in Belgium and Luxembourg, and Frank Dendas, who is the Country Manager and the Commercial Director of Healthcare Systems at Philips Belgium, Luxembourg. Welcome. So the first question that we have, it's a question for Arlette. I'm going to use my glasses. Caregivers are frightened about the black box syndrome of the artificial intelligence solutions. Besides, when you establish artificial intelligence solutions in order to help caregivers, how can you adapt this in the changing world where there is change in sickness, in definitions, in solutions? So was the question clear? I don't know. Arlette, it was a question for you.
Is it also in the screen? The question?
It's in the chat box. It's in the chat box.
Oh, that helps me. Thank you. I'm reading it. One moment.
Okay.
In order to help caregivers, how can you adapt in a changing world with changing definitions and solutions? Yeah, there were two things. First of all, the idea to have a black box in terms of artificial intelligence and to trust that solution. And the second thing is, in a changing world, sickness, people, devices, and so on, how can artificial intelligence adapt to that? Yeah, so I presume the black box syndrome of artificial intelligence means that you don't have control anymore. So I think the fear comes from losing control, is my assumption. And I think that's a stepwise thing. Just as we slowly digitize the financial sector, which is a complete digital world by now, everybody took steps in trusting these technologies. And I do think that some things still should be in full control of physicians as well. So I would always say, start small and take it step by step and gain the trust. And I also think that young doctors are educated by this. So they grow up using these technologies. And while my dad still tends to get his calculator next to his Excel file, I would never dream of doing that because I trust Excel. So that's, and we've got other ways of controlling that. So there is ways of also digitally checking whether things are correct. There's what do you call that, failure nets to implement to prevent things from going wrong, because humans can also make mistakes.
Yeah.
Do you have anything to add, Mark, maybe?
Yeah, I think you're spot on, Arletta, and I think artificial intelligence is a very broad umbrella term for lots of different applications of data interpretation. So we know, and we've seen in healthcare, probably the most prominent and successful uses of artificial intelligence have been in things like digital pathology, reading images, where actually it's been proven to be more effective and quicker than humans can do, and less likelihood for mistakes. But that doesn't mean it replaces humans. It means it really augments humans. I think where it gets more challenging is in dynamic environments. You know, images and pathology slides are static, and they can be compared to benchmarks, and you can learn, and machine learning can say, I've seen this pattern of unstructured data 1,000 times, and it's always been this. When you think about the challenge of driverless cars, you know, where really artificial intelligence is trying to perceive the surroundings, it's then trying to predict patterns that are going to happen now and in the future. So what are other cars going to do? And then make decisions. So those principles still apply, even if you're thinking about a healthcare, let's say patient flow, where you have a capacity that you're trying to access. You perceive the situational awareness of what capacity exists. You predict how the demand is going to change, and then you make a decision on what's the best placement of a patient. That's a very simple example. Artificial intelligence in that simple way can say, well, the 3 best options for placing this patient right now are these 3 locations. It's still your choice. Like our GPS systems, it can say turn left and you can decide to turn right. But the application of artificial intelligence is to augment decision making at the moment. It would never, or I can't envisage a time where we automate processes so far that it's a black box and we're just watching what happens. That really is somewhere in the future, I would say.
Okay, thank you.
Thank you.
Yeah, a question for Mark. Connecting patients and caregivers seem to be important in patient care improvement and care integration. How could this be implemented when there is no such care integration in care organization and financing in the country? And we have, yeah, here we come to some local aspects of implementing digitized paths. I don't know who is the person who will answer that.
Yeah, maybe I think this is Frank speaking. Good afternoon. I think there may be 2 views. One might be the one that Mark has to share, and one that might be the one that Rudy and I have to share on a national level, because the remark is spot on again. And it is, we have high complexity in many cases in Belgium. We have too many governments, and we have, let's say, 4 to 5 levels of, let's say, how we can look at this problem. The first one being at micro level is the hospital itself, or it is a group of hospitals, or it is a network, a group of networks, and it could be on a national level. So that all depends on how can we integrate this, and what kind of communication do we need to have with different, let's say, lobbying or power groups within Belgium. So I think it's a joint effort, and it's an approach that we should be able to scale, and that we should be able to have a dialogue with, amongst others, with government officials, but also with the hospitals. So I think the remark is quite, is correct. And I think it will be a long-term process. But as Arlette said, I think it's a matter of starting small, having a few pockets of excellence, and then grow from there and see what we run into. Who do we need to speak to? Who do we need to sensitize? And one remark that I heard last week is also, you may not exclude anybody. So all layers of caretaking must be integrated there, so you can leave nobody out. Otherwise, the system will not work. That would be my input. So acknowledging what you say, and I think it's a joint step-by-step effort. And let's start small and build from there. Maybe, do you want to comment?
I think just one thing that we saw due to the COVID is that, for instance, like telemonitoring or teleconsultation, this was already talked about for many years upfront, but not moving forward. And unfortunately, an event like the one we are having this time, suddenly everybody is waking up and making big steps forward, looking into it, and trying to find an integrated way to make it viable in the market with the systems which are in place. So it's sometimes you need some events to make a step forward, but small steps, as you said. And sometimes as well, what we hear is that doing first something and putting in place to prove might also, small projects might also help moving forward in the reimbursement system and in the approach of the pathway.
Yeah, and if I add one, Mike, sorry, if I may add one, I think it's also a matter of, at some point, you just need to get started. We need to take a decision to say, okay, if we find a partner and we would prefer to be with us, but it doesn't make a difference who you talk to, but just let's make a start and let's just see what we run into and learn from there. And then we can expand and then we can scale. Over to you, Mike.
Yeah, I'd build on exactly those comments really, which is that you've heard us talk about, and you probably know Philips is pioneers in design thinking. And design thinking says that you start with the need and you start with the problem you're trying to solve, not the technology and the solution. So we believe that maybe teleconsultation might be the answer to the problem, but if we're very specific about what the problem is we're trying to solve, we can quantify the value and the impact versus the investment required. And it's our job, myself and Arletta in our part of the business, to work with healthcare providers to say, we don't expect the government, the hospital to spend a penny on technology or investment unless they can see a clear return for their patients, for their organization, for their consumers and their public. It's our responsibility to help you quantify that and to do, if necessary, small proof of concept, pilot projects, data analysis to say, you know what, this is going to be a bigger impact than maybe some of us perceived. Perhaps there's a cast iron case for investing in this kind of technology at scale. But you start with what is the problem you're trying to solve, and work from there. And I really encourage. I've been working with a hospital in South Florida, literally last night for a couple of hours session, where they were identifying the same challenges and saying, well, we've tried this before, we've got pockets of technology that kind of work, but we're not really seeing the return. And I'm saying, yeah, but have you actually got really specific about the problem you're trying to solve? And then we can talk about how you apply technology and data and analytics and the change and the behavior that needs to wrap around that to get the real benefits that you're looking for.
Yeah, so another example that I actually wanted to share and I forgot is that we work at a hospital to optimize the surgery department for intestinal surgery. And basically, we wanted to take this approach, and along the way, they bought 50 virtual reality glasses. So we said, okay, now what you're going to do. So they're actually looking for a purpose right now to use the virtual reality glasses, which seemed such a brilliant idea to buy. So now we try to turn it around and find a purpose for it, but it should be the other way around, in fact.
Okay. So suggestion is to start also small and see the benefit for the patient and work from there and try to find a good business case in order to do something about it. Another question that I have, it's a little bit related, I think, to the quadruple aim. Some experts argue that the goal of digitization is to give time to nurses and doctors for patients and for replacing administrative tasks. What do you think about that?
difficult to decide who will begin.
I need to pause.
Go ahead, Mark.
Okay.
You're on
Mark,
mute
I
now.
can't hear you.
You're on mute.
Mark.
I apologise. Can you hear me now?
Yeah.
Yes, I can. Thank you.
I come from a background of lean operations, lean technology, removing waste, etc. And much of the work I did in my early days with hospitals was about transactional lean, about administrative tasks, about process automation. That's, of course, we should always be looking for ways that we can be more efficient in that sense. But most of, if not all of what we've talked about here is directly impacting our ability to efficiently deliver safe, high quality, reliable care for patients at the point of need. And I think in many respects that does entail being much better, slicker, having much higher level of process governance for sure. But it's not about reducing someone's workload or even affecting the staffing. It just means that people will work differently. I don't envisage for a moment that we're going to need less people in the healthcare environment. I just think we might be able to make more use of that valuable capacity in a more efficient way. That's my view. I would never start from the view of saying, and reduce administrative burden. We hope that's going to happen along the way, but that's not the primary aim.
Okay. Just one more thing to add, if I may, and that is that, how should I put it? I think that the choice of partner to work with is very important, because if the system is not working and running as it should run, then technology is only a catalyst, right? It's not something, it's not an end goal, which means that if the technology is not, or the backbone behind it is not okay, then in that case, it will be an accelerator of chaos. If you put the right system in place, then it will be an accelerator of efficiency. And then it's not a matter of, hey, do we need less people? It's just a question of, as I think, as Mark said, that people will have time to take care better of patients and to do actually what should be a little bit of the sweet spot and what makes them choose the job in the first place. So I think it's a combination that you need to find between, okay, what do we want and what is the technology that can realize that, and then you will see the positive effects of what we shall put in place. And as we said, let's just pick one let's say pocket of excellence and go from there.
Okay, thank you. The next question is also something that is happening in my hospital during the COVID crisis, or the first peak. Digitization had strong support within the organization. We now notice a clear decrease in digital use. What could we do in order to maintain the support for digitization?
I can respond to that. We see that in many hospitals, and part of the reason is that people are tired because it's an ongoing struggle. I was at a client yesterday and they say it keeps going on. So I asked, are you settled down a little? No, we're not, because COVID keeps happening. And that has to do with the ability to adapt change in people, which is a very natural thing. The stretch ends at some point in time. And what you can do, you cannot fix this. People have limits. But I do think there's a few methodologies from change management practice that you can actually use to help people to adapt technology. And that has things to do with, at one hand, facilitate them to be able to use it. So give them the time to use it, give them the tools to use the new digital way. So if they need help, provide them with help and make them see, but they probably do, the benefits of this digital solution compared to the old situation. And even if you go for the harsh way, take away the possibility to use the old situation, depending on what solution we're talking about. So this is a little bit abstract like this. There's different ways of nudging people into change and making it stick.
Yeah, and I think a very powerful.
Oh, sorry. Go ahead, Mark. I will come after you.
Oh, I'm sorry, Frank. Yeah. Just very quickly, then I was going to say that a very powerful way to ensure a change acceptance. You know, our letter referred to the change management. Is that the people receiving or involved in the change are involved in how the change happens from the beginning. So just as I've done many times when I've been implementing, for example, I mentioned command centers. Every time we designed an analytic or a screen or a tool to support decision making, the team that surrounds that problem were involved right from the inception. The first designs were back of a napkin drawn by the nurses and the support staff and the health professionals that were involved. And therefore, as we went through the change, they were excited about receiving whatever the end product was. And they were already gearing up for change, and we would rehearse, we would activate the change by saying, before you get this technology, let's rehearse how you're going to behave differently. Let's talk about what happens when you see that alert or that threshold. What happens now? And we would do tabletop simulations and we'd mock things up. And it's just really all about change. It's always uncomfortable. But if you feel involved, then you feel committed. If you don't feel involved, there's no commitment.
If I look at the situation that we had a sense of urgency, but it was a top-down approach that we had. So we needed to do this or that or whatever. Now in the new situation, what you suggest, Mark, is to go more from bottom-up approach. What are the needs of the different departments or the needs of the different caregivers, and then work from there? Is that a good indication?
Yes, exactly, Geert. And I think it's you have to break it down because there's probably 100 things you could go after. So back to this, you think big, you start small, but you act now, and you choose those 2 or 3 things that feel really important to everyone. And to really drive sustainable change, then you have to involve those people that are going to be of a vested interest, not just stakeholders around the outskirts. But if you're going to ask me to behave and act and work differently, I want to have a say in how that looks and whether it's useful. And don't give me something that's easy to use or easy to access, etc. So it's just it's really a proven path, I think.
Yeah.
Frank, I think I interrupted you, so I.
Yeah, the first one was my same, and then the second, if people abandon the project, of course, then understanding, asking them why are you abandoning the projects, because people should see value in there, and if they apply it and they see, hey, this speeds up things or it facilitates me or it's easier to work with, then yeah, I hope that they will stay with the project. So asking them and understanding why they leave the project is also very important, I think.
Okay, next question was more to Arlette. The ACS example is much like what was done in the Gesundes clinic style model in Southwest Germany with Optomedis for cardiac insufficiency patients. Benefits are huge for patients, but couldn't be brought in without a real financing reform. And that takes into account out of hospital care. So that's maybe also a remark or a question that also was referred to in one of the first questions. Arlette? It's also on the chat.
Yeah, so I don't know this particular example, but it's always a challenge to get the financial structure around this. And I personally think I've been at Philips for a few years now, and there are some great solutions that were there all the time, and only now during COVID somehow it happens in practice. So all of a sudden the money is there and the financing boundaries can be broken because there is a sense of urgency. And that sense of urgency is not only from hospitals, but finally also lands with insurers and ministries, government. So what we did before in a whole different example for dermatology care is that we made a group of people from government, hospital, first line care, and very important, the insurer. And we made some new agreements on how to fund dermatology care before actually bringing innovation. And that I must be honest and say that doesn't work out a lot of times, but this was a great example that we managed to fix this beforehand and have the insurer say, okay, there's a big pile of money that we usually spend on different silos of care, and you are allowed right now to take that whole pile and spend it as you see fit, using this innovation as around one patient and not within different care silos. So I think it's an important prerequisite to make innovation or digitizing care succeed. And you should involve insurers, particularly at the beginning of the process. It's a good remark. I totally agree.
Okay. Another question, also a little bit related to financing. Can a reform in healthcare financing for fair payment for pathology, the situation I believe in the Netherlands, instead of payment for a medical procedure like the Belgian situation, accelerate digitization?
I think so, yes. I'm not, Frank and Rudy are more familiar with the Belgian system. So to say something about the Belgian market is more easy for you, I think.
Well, indeed, the system, the payment system, let's say, paid by the procedure is of course putting some focus on certain elements of the operations of a hospital. If we think and the holistic approach, the integrated approach of the whole health continuum, for sure might have a better overview and a better perception if treatment, if pathology would be reimbursed instead of the act. So it would push the caregiver to look at the whole process maybe a little bit more than in separate stages. It would help the integration of the whole process.
And I still think also in the Netherlands there's too many perverse incentives still also funding by pathology, because the funding gets higher depending on how you classify the pathology, which gets more expensive if you put in more exams, more nursing days, more whatever. So let's say somebody needs an appendicitis, you can make that something bigger, even though the patient doesn't have it. Not that doctors do this, but there is a weird incentive. So I also think that the system that we have here using DBCs or DOTs, so they're called, has room for improvement, and still it's only focused on hospital care. So there is reimbursement for other types of care, but it's organized in silos. So that's still not really by pathology, but by organization, in fact, healthcare organization. So there's a lot to win still, I think.
I think we covered all the questions. There are some comments about artificial intelligence, that it's not really a black box, and the fact that a CIO of an IT person should be on board on the board of directors and things like that. But I think we covered most of the questions. Are there some other thoughts or things that we should take away from this discussion? And I'm looking now at all the members of the discussion.
Not just an IT person in the board, but also a chief experience officer.
Yeah. Okay. Thank you very much for this enlightening discussion, and also of the good presentations. Also, Mark, thank you for sharing your international experience. And we hope that we can also implement it into the Belgian situation. As you heard, it's not always easy because of the financial system that we have in place. But I don't think that this should be an alibi not to do it, because we do it for the patient, and that's the most important thing. And we, like you said, we have the technology in place in order to do it. So thank you very much, and I'll now close the discussion. Thank you.
Thank you.
Thank you.
Nu wacht ik nog. Ja, oké. Ik weet niet dat wij nog online zijn.
Nee. Ik zie dat Mark ook al weg is.
Ja, Mark is wel weg. Ja, er waren ook nog heel positieve commentaren op Mark zijn presentatie.